think that'll. And then this may or may not advance. Which will not advance. Right, so you can choose this.
Which one advances?
This is not advancing.
I roll that.
Yeah, that's. I can, let me. Lock position. Doesn't go to that spot. There we go. I think that's what I have. Mine feels over reverse. Okay, it wasn't locked. And then. Oh, pointer's a challenge.
Okay.
For several reasons. It actually does kind of have a pointer, but let me see.
Oh, yeah, it does. That's good. Oh, cool.
Yeah, there you go. You can change it too, but it's not, it's a funny thing.
It's great.
Yeah, it's pretty good.
All right.
All
Hi.
right. Hello. You're gonna sit, you're gonna sit or stand.
Uh,
You can do whatever you want.
I like
your
stand.
emeritus, okay.
should I stand in front?
Yeah.
Okay, good.
This is the Honorable Dr. Pavan, Chairman Emeritus,
That's right.
kind enough to come out and lecture to us today.
Nice to see you guys.
Oh,
Hey,
yeah.
Al. So, this,
Oh, but you guys should listen to the lecture. Why don't we get it after the lecture?
is that all right?
Yeah.
I don't want, I don't want your blood sugars to get low. Okay, so, I, came here and I was a retina guy. And, I then got into, and Grizzard and Hammer got into the comb study. And Hammer showed me how to do plaques, because I wanted to be part of it too. So we had two centers in Tampa, one at the university, one here. The comb study is the collaborative ocular melanoma study. Have any of you ever heard of it before? So it pretty much established a lot of good knowledge about how to treat melanomas. And in particular, it established that plaque therapy gives you as good a survival as enucleation. Let's see. So this is old school. I mean, this study went on in the 80s and 90s, I think.
Yeah, I was actually part of the comms.
Were you? Really? Good. And there was over a 99% accuracy in the diagnosis. That's a little bit of a hedge because they excluded anybody who had a lesion that they weren't sure was typical. So, there's a selection bias there. And what you should know is the diagnostic accuracy is based on all the information you can get on a patient and on their eye, because it is nothing pathognomonic about a bump in the eye. And so you have to take all the information and put it all together. And so it's going to be your clinical exam, your photography. We used to use fluorescein, B scan. Does anyone do A scan anymore in the department?
Only for like axial length for.
Yeah, other than that,
yeah.
tumors. Yeah, A scan is an art that's sort of, I think, dying. The other thing that I found, and this will come out in the lecture, for diagnostic accuracy is time. Watch, if you aren't sure, you can watch a lesion over time. And sometimes that will give you an answer one way or the other. What did you just do? What did I just do?
No, I did something. I picked up the mouse.
Oh, okay.
Put it back down.
So the classic melanoma, you all know this probably. It's dark, pigmented. It has a dome shape or a mushroom shape. They talk about double circulation on FA. I think that means, nobody ever explained it to me, but I think what that means is you have the circulation within the retina, and then within the tumor, you can see vessels. And so that's the other circulation. So you have two circulations. I don't think double circulation is particularly diagnostic. because other lesions such as hemangiomas will have that too. In fact, even AMD will have a double circulation, right? So I don't put a lot of weight on that. And then the thing about a melanoma is it has a low internal reflectivity. And that really helps in the diagnosis. It has some reflectivity, but it's low. Okay, so here's a typical melanoma with a double circulation. And is there a pointer here? Where would the pointer be?
that top thing, that little button on top,
That little button on top.
and it might work.
Yeah.
There you go.
So this nice dark part of a dome-shaped lesion. And this was taken with an old camera, so we don't have the wide field. You can see a little bit of orange here, actually, and that is something we'll talk about. But that is typical of a melanoma. And down here you see the two circulations, one above the other. This is a typical dome-shaped lesion. It's often very smooth. It has lowish reflectivity, but it has reflectivity. And this is a attached neurosensory detachment, exudative, and you can see that's completely without reflectivity. So you can see the difference there. This is an A scan. You have no idea what it is, right? I don't want to spend a lot of time on this. It's another lecture, but this is a measure of, this is the peak of the tumor, and this is the peak of, I think, the inner sclera. And the difference between that is the thickness of the tumor. And this is at tissue sensitivity 67. Is this at 60? Yeah. So the machine is calibrated such that this is called tissue sensitivity. And if you have this big dip in reflectivity internal to the lesion, that is called low reflectivity. But notice you have some reflectivity. It's not hollow. This is, if anything is going to be pathognomonic, it's a mushroom shape. And Jerry Shield published an article years ago now, where he described other lesions that can have mushroom shape, but it's reportable. Okay, so if you see this, it's pretty much you got your diagnosis. Okay, and what you see is the dome here, and then it broke through Brooks' membrane and is growing out into the subretinal space. Let's see.
It's not the best.
I don't know if. I think.
Are you trying to see the video, or
Yeah, I want to do the video. So how do I go backwards? Here we go.
maybe I can click here?
Yeah,
There you go.
there you go. Now there you see the reflectivity within the lesion, and those are vascular pulsations, I'm told. And so that is that establishes a circulation within the lesion. And that's what it looks like on some lesions on B scan. You don't always have to see that. In fact, you see it in a minority of cases. Okay. Do y'all know this? From Carol Shields. To find small ocular melanomas using helpful hints daily. So each one of these characteristics on a lesion helps you decide if it's likely to progress to melanoma. And there's a certain statistic increase in likelihood with each one of these. So if it's greater than 2 millimeters thick, if there's fluid associated with it, if the patient has symptoms, if there's orange pigment, if it's within 3 millimeters of the disc margin. What's 3 millimeters? What's 1.5 millimeters?
The disc.
The disc, so 2 disc diameters. Any part of it, okay? If it has ultrasound hollowness, which we talked about, if it lacks a halo, halos are good. And if it lacks drusen. So if you have drusen and a halo, you're really off the hook. So this is a typical benign looking lesion. It's more than 3 millimeters from the disc. It's flat. It has no orange pigment. it has drusen. It does not have a halo. That's the only thing. So this would be unlikely to grow. But, and this is showing that it doesn't have any internal circulation, just staining of the drusen. Halo, this is a halo. You see the halo around it?
That's a big halo.
Yeah, that is a big halo.
I saw one of your halo patients this week.
Good, good.
She said you, and she actually saw Carol Shields, and she said Carol Shields and you used to march her around for everybody to look at her.
Yeah, okay.
Halo.
So this,
Eichenbaum's trying to get in, so. Try to guide him here.
oh, okay. So, the halos are good. I'm missing, this is it. So you don't have to keep it all in your head. If you have a smartphone, does Stricker still have a flip phone? I can't believe it. He's just being stubborn, isn't he, huh? All right.
His old phone stopped working when like 5G happened, and so whatever like company he uses sent him a new flip phone that works with 5G.
Wow.
He's a very smart guy. Why he won't switch, I don't know. Anyway, you can just go in here and plug in your factors, greater than 2 millimeters, no, orange pigment, no, and so on. It will give you a likelihood. It is amazing when you do this. If you play, you should go in and just play with it, because some things like orange pigment, you just see the chances are that it's going to grow within 2 years, just soar. It just one factor, and well, you're toast. You better watch out. This I came across, and I didn't even know it. It's amazing how I'm going senile. But this was a case presented apparently on this day in 2014. So that's 8 years ago now.
Yeah, we used to be at Children's. That was nice.
And
Mom,
yeah, it was right near your office.
Yeah.
I got to drive. Payback's a bitch, right? So anyway, and I found it on one of my thumb drives, and I do not recall anything about this case, except I was able to locate some data, and I know the patient had sickle cell. But they also had this, which is a very small lesion. It is flat. And it's doing good, right? It looks pretty benign, but it was referred to me, so we started to follow it. Well, it wasn't flat, but this is not 2 millimeters, okay? This is that's a 0.5 millimeter elevated on OCT. So and it's very smooth, nice surface.
It's nice you had an SD scanner in 2012. I think that's when they first came out.
2014.
Yeah. This is 12.
Oh, 12, okay. And this is a fluorescein. They probably got it because the patient had sickle cell and they were looking around. And you can see that the lesion has no internal circulation. I mean, this looks like a very innocent lesion, okay? But fine. So they followed it. So almost a year went by, 10 months? And something's changing here. You can see that it's a little bigger. If you notice, use the vascular markings. It's expanded on this edge for sure, and probably on the other edges. You can see a slight expansion. Okay, so then, but it's still very small. I mean, this would have if you put it in the calculator, it's going to have a very low chance of growing. Right? But there it is, another year, and I don't know why we were following this at this point, but this sucker's mushrooming. That's a mushroom. It's broken through, and typically the mushroom part is hypopigmented. Can be hypopigmented, not always. Sometimes it's very darkly pigmented, but this is very. It is mushroom. It is now clearly, and it is. You can see the base is expanded tremendously too now. And it was a very innocent lesion to begin with. And now, look what, this is impressive. Even, did somebody gasp there? I don't know why we were still watching it from here to here. But look at the rapid expansion. This is, in what, that is 4 months. And that is I know why I have this. One of my, medical students reported this as a rapid growing lesion. And, got a case report out of it. That's why it is. It's a 4-month period. We shouldn't have been watching it. Maybe the patient refused or went away for the summer. I don't know. And this is the lesion in cross section with the V scan. And it's just summarized what we just went through. And this shows you from here, from over or from March to 2014. So that's a year and a half.
So they don't typically progress that quickly in general,
No.
2 years.
No, well, the last, once it broke through that last 4-month period,
Yeah.
that was very rapid. And there are the doubling time in the literature, the record doubling time for melanoma is 17 days.
Wow.
So they can grow slowly, is what you could, or they can, once they break through Brooks especially, they can really take off. So
do you remember if you did a plaque or did that eye come out?
I have no recollection. I'm senile. I don't know. I mean, if they moved the entrance to the hospital, I'd still be walking around outside. I would never find out. So, what about the features of metastatic disease? They're quite different, and often you can tell the difference. And this is going to be, there's a lot of metastatic disease out there. There are relatively few melanomas, but typically the lesions, and they all look the same. It does not matter the source. Okay, it does not matter the source. They're pale, they have leopard spots. We'll show you some of those. They're low, they're not dome shaped, they're placoid. I'll show you in a minute what that looks like. They're multilobular. If you have a lesion in one eye and a lesion in the other eye, and it's a woman, the chances are it's going to be breast. I mean, it's as simple as that. Or multicentric or 2 lesions in the same eye. If they're multilobular, I've seen melanomas that are multilobular, but that's more typical of metastatic disease. And they have variable internal reflectivity. Large melanomas can have some variability, so that's a soft call. Again, except for the mushroom, it's the totality of the data. It's not one piece of data you can hang your hat on. I have no idea what I'm looking at. Okay, let's see if I can figure it out. Well, I can if I can't advance. Okay. So that was a placoid lesion. I must have thought it was metastatic, and here it is, placoid. So that you can see how pale it is. I'm too close to it, but over here I can see, I feel there are some leopard spots there. So just on the appearance of this, I think it's metastatic. Changes my whole approach to the patient. Okay, we're not talking probably a plaque here. We're talking a workup. Where's the primary, external beam, maybe, totally different. So it makes a difference which road you go down. Again, it's placoid. Here's another lesion. It is pale. It's probably placoid. I don't know if I have proof of that. And there's a hint of leopard spots. But you wait, and over time, the leopards, this is the same lesion, just a little bit later, you get some leopard spots.
Is that
And
from
they even get
stretching?
worse.
Do you think it's from stretching the RP, the leopard spots, because it grows and?
I have no idea. Okay, I never even
Curious.
thought about it. You know that?
Yeah.
You're too intellectual.
It's an interesting, because it looks like
I just have no, I mean, it is what it is, okay? I'm old, easy on me,
Not that
okay?
old.
And here is, you can see the multilobularity of it, okay, like this. All right, see the bilobe? And this one, I think, yeah, I can tell, I remember this is thyroid, see? That's how I remember it, I can read, can still read.
There.
I remember this woman, it's very sad. She had thyroid and she was going downhill fast. Pale lesion, she had known metastatic thyroid, walks in, I mean, it's a horse, right? It's a metastatic lesion. Leopard spots develop. And then I'm not sure, I never saw her again, so that's, it's very sad case. So now so we got melanomas or things that may become melanomas you gotta watch out for. Then we have the metastatic. Now you've got a whole other thing, which is nevi, okay? And that's sort of the melanoma nevi thing. It makes a huge difference which path you're going down or what you're thinking is, if you think it's in the melanoma nevi category. And probably well over 40 years ago, probably in 1978. So how many years is that?
Many. That was good.
How many?
20, 22 and 23, 45.
45 years ago, Grugutis, when I was a resident, mentioned in conference, we'd have a conference of maybe 5 students or residents rather, or 2 residents and a post-resident guy, and we do a flourishing conference. He mentioned the telltale nevus. And I didn't pay a lot of attention to it until I put together this lecture, and I went back and looked at a bunch of amelanotic nevi. They're the challenging ones, right? It is incredibly common, the telltale nevus. So you have this lesion here, which catches your eye, no pun intended, and on the edge, you have a nevus. And it is from this nevus that this lesion grew. There's another one. There's the telltale nevus on the edge, right there.
So are those melanomas growing from nevus? Or nevi
No,
growing?
they're nevi growing from nevi, but they are amelanotic.
Okay.
Okay, at this, we think, okay? I would watch these every 3 months, okay? So here, and it's not trivial to slap a plaque on this, you're gonna cost them their vision, And if you can, sometimes you can fall, I have one lesion that, I remember the guy, he had all the high-risk characteristics by Carol Shields mnemonic, okay? He had like 6 out of 7 of them, or 7 out of 8. And I followed him for like 15 years. It didn't move an inch. It didn't move an inch. So it's all very individualized. But these things are very common. I mean, I think this is the nevus here, right in there. And I'm calling this a nevus. Maybe not. I may be pushing it there, but they're very common. They're very common. This one I treated with a plaque. This is a melanoma arising. But so I'm going down a different road. I'm thinking melanoma. I'm not sending them out to the internist. I'm not hunting for a primary, probably. They may get sent to the internist, but I'm thinking, I'm going to have to follow this patient. This is probably a melanotic nevus melanoma type lesion. So sometimes you don't have the telltale nevus. So what do you, there are no leopard spots. It's more dome shaped. It's single. It can be acoustically hollow, but if it's a nevus, it may not be acoustically hollow. It's better if it's not, if it's more solid looking on B scan. And you find no other primary cancers and you follow it over time. Fine. time. Don't forget time. This is a funny lesion. This is this is an elevated pigmented lesion. Do you know what it is? It's slightly elevated, it's about a millimeter and a half. You're not allowed to say. Okay, you know. Okay. Now do you know what it is?
Is it just a CNVM?
It probably is one hidden in there. You're on the right track. This is a rip. This is an RPE rip. So the RPE, see, it ripped away from this area here and pulled down here. And so it's all clumped up. And that's called an RPE rip. And it has a certain mass to it. I think my classmate, Herb Cantrell, was on the paper that originally described these out of Minnesota. And it can be dramatic. If it involves center, there it configures vision. And it happens like that. At 8 o'clock they can see, at 8:01 they can't.
Well, now it
they're
happens
very
after
fast.
shots.
Huh?
That's what sucks, right? Now it happens after we treat people. So you give them a shot of Vabysmo or Eylea and it can.
I don't think that it has anything to do with your shot. I think it's bad luck.
Well, bad luck and the shot.
You know.
I've seen it afterwards. And then they come in and say, why am I,
Why did I say
Yeah.
you treated me and I went blind?
Right, yeah.
You're a great doctor, right?
Yeah.
Yeah, I've been there.
How fast do you see it in your experience anecdotally after you give the injection?
Oh, like 5, within a week. Within a week. And I've had some stress. I had one I had on Lucentis for a while, was non-responding for, I think, a year or two. Eylea came out, switching by Eylea. 2 shots later, hemorrhage from an RP, because it's stronger. That's why the Vabysmo.
As soon as we saw that last
Pardon?
night, they went over the label on one of those steak
Vabysmo's the
dinners. There's a numeric increase in RPE RIP in Vabysmo's label versus the Eylea active control, but it's 3% versus 1%. So who knows what that means? It could mean nothing, but there is a
statistically significant.
Of course not. These studies are not powered for those tiny
Thank you,
numbers.
thank you,
Of
yeah.
course not. But BOVU was never statistically significant for causing a severe intraocular inflammation. There's no epidemiologic
But
evidence.
everyone knows it does.
Exactly.
Like parachutes or whatever.
Yeah.
That's not good.
Yeah.
Lies, damn lies, and statistics. So there are other lesions out there you're gonna see. So this is the differential diagnosis of malignant melanoma, the choroid, but it's really a spots and dots lecture of things that you might confuse. So here's a lesion that's below the disc. It has what looks like a telltale nevus. So you do a B scan, right? Among other things. I took a photograph, I did a B scan. I'm not sure how elevated it was, but and boom, it wasn't elevated at all. You can see that. But who can tell me what's going on here?
There's an acoustic shadow.
Right.
Pretty prominent there.
Yeah, here's the disc. Here's the disc. But here you have high reflectivity and a huge shadow. That's calcium. For years, I got this confused. I thought, oh, that's an osteoma. It's not. That's not what an osteoma looks like. That is a calcium deposit in the sclera. And because of that, you're obligated to get a calcium and a phosphate. Okay, or phosphate, I can't remember which. So it looks more typically like this. You'll look in the eye and you look in one eye and you'll see this, and in the other eye, you'll see something a little less prominent, but it's elevated and it's lumpy, bumpy. And it's almost always in this position. And I don't think it's due to the insertion of the superior oblique. I have no idea why it commonly occurs here, but it does. And on ultrasound, it is dramatic. So it's wonderful. You can say to the patient, you're fine, nothing bad's going to happen if you don't die from hypocalcemia. You don't have a tumor that's causing this, and your parathyroid, we're home free. So you get the study and then you're done. Or you send them to their interns. Okay. This is an osteoma. This is what they look like. They have a very sharp border, and they are typically pale. And they are very placoid. And they have reflectivity. But this is a, what is it, osteoma hamartoma or something like that? Anyway, it is not associated with abnormalities in the calcium. And by the way, the other entity with calcium deposit in the sclera, usually there's no calcium abnormality, but you need to check for it. All right, we're gonna switch. You're gonna have to sing. I'm gonna sing it once, and then you're gonna sing it with me. And you better be in tune. This is being recorded. Are you ready? I'm gonna sing it once, all right. Mud, mud, glorious mud, nothing quite like it for soothing the blood. So come, let us swallow down in the hollow in glorious mud. All right, are you ready to go? Are you ready? Did you have the guy? I got this from a Harvard lecturer.
I never heard you sing. Good.
Well, there's a reason I can't, and I just proved it, right?
We're ready.
All right. Mud, mud, glorious mud, nothing quite like it for soothing the blood. So come swallow down a glorious mud. That was pathetic. I mean, that was truly pathetic.
The best thing I heard in a lecture.
We're gonna do it again. All right, I want some enthusiasm here. All right. Mud, mud, glorious mud, nothing quite like it for soothing the blood. So come swallow down a glorious mud. C minus, but we pass. All right, blood. Blood is dangerous. Blood got me sued. I took out blood and I got sued. I would have lost $750,000 because I enucleated an eye with a hemorrhage. Except for the fact, before we could settle, patient died. Yes.
This is recorded. We got it. It doesn't go anywhere.
Now, I gotta tell you, that yes wasn't my idea. It was my secretary. When she took the message and found out the patient had died.
Yeah.
Somebody said she went, yes.
Because
And she
you can't.
And she was the sweetest secretary I ever
She
had.
was.
Was that Mary? Yeah.
Yeah.
Mary was really sweet. Yeah.
And
Being sued is horrible.
so
Horrible.
So- anyway. I was in a hurry. I didn't pay attention to the one factor I told you all to pay attention to. What's the one factor that I was? Time. How it evolves. Blood can be very dangerous. It can be dark. It can be dome shaped. It has low internal reflectivity. Okay. But there's no double circulation. But I'm telling you, when you do a fluorescein, I'll show you in a minute, you could have fluorescence. But it regresses with time. Time is your friend here. Melanomas bleed. Just because I'm saying you see blood doesn't mean it's not a melanoma. Melanomas actually probably bleed fairly frequently. They have a fragile circulation. When they break through Brooks, this is one breaking through Brooks. It's now coming into a mushroom stage, and you can see the blood on the edge. Blood doesn't rule out a melanoma. Okay, so I'm not saying that. So you got to use your head here. That's this lesion. You can see it's now breaking out. You can see it's bled down here. Notice the reflectivity is the same. It's so that's not going to get you by, is it? You can see the edge of the tumor here. This is not tumor. This is blood. This is a scan. I hope you enjoy it. But I have no idea what it is. It's probably that tumor. And it's just showing the low internal reflectivity, but it's tumor in blood. I mean, you can't tell the difference. All right, blood can go into different places in the retina, and where it goes makes a difference. And I've thought about this a lot. Subretinal blood, you've all seen it. Intraretinal blood, you've all seen it. It's bright red. There's nothing between you and the blood. What color is the retina?
Clear.
Thank you. It is absolutely clear. But it's the only reason you guys can see a detachment is it becomes unclear because it becomes edematous and opaque. But in its natural state, it is clear. You know, it makes no sense the way the retina is organized. When I first read in a histology book how the retina was organized with the rods and cones on the underside of the retina, I said, this book's got to be wrong. You want the rods and cones up there, right? But then I learned about the shedding, etc. So God got it right. He put it down there so we can shed all our rods and cones at night, which is about 25,000 we shed every night per eye. It's huge. And then the choroid takes it away. But anyway, that's another story. So that's easy. And it blocks. This is an interesting lesion. For one, you see the subretinal blood, but this is sub-RPE blood. Notice the color. It's dark. If you saw that and you didn't have this circle around it, you would be very concerned that you had a small melanoma there. Okay. And if it's a little bit elevated, it's going to have low reflectivity. Notice it has fluorescence. And the reason it does is probably under the choriocapillaris. So the choriocapillaris, it's in the choroid, it's sub-RPE, but it's more than that. It's sub, at least to the choriocapillaris, because that is now filling with dye. So this doesn't, because you see fluorescence, doesn't rule out blood. Okay, this is probably an ectopic disciform here that's going on. I do not know why I watched this lesion, but I did. I think it may be, this is a very dark lesion, right? It's blood. It's blood. Can you believe that? You look at that, scheduled for the OR. And I am sure towards the end of my career, I got fooled again. Because I put on a plaque on a guy and he came back 6 months later and there was no trace of the tumor. And he had a fairly big one, 4 or 5 millimeter elevator. And I was thinking, well, sir, your tumor's gone. It's really wonderful. I just shot. I had no proof that I goofed, but I knew I goofed. But I wasn't gonna. I've been sued once. I didn't need it twice.
The real malignant ones can go away quick. They can flatten.
I have
Not
never
common.
seen it. I have
Okay,
never
great.
seen that. I mean, this was no pigment change, nothing.
Oh, just gone.
It was the most normal looking peripheral retina I'd see. Okay, maybe a few drusen, but this thing looks very dark, right? That's RPE, but along this edge, there's a little bit of hit. Okay, there must have been something in the history that made me wait, but I used my time thing. Okay, so here we go. And it fluoresces. It fluoresces. And it's fairly low internal reflectivity and it's dome shaped. By all criteria, I should be, calling Faras. And do you use Faras?
Now I'm not doing plaques right now.
Okay,
That'd be
good for
crazy.
you. Smart thing.
Well, now I want to.
You want to,
I'm gonna
huh?
get the
Why, you need the
infrastructure.
radiation? So
All
anyway,
my babies.
anyway, it looked like it, but this is time. And time, look at how small it got. I think these are the same dimensions, but look right there. And then notice how, right there, see, it's gone way back.
Mhm.
It's come way down from the top, okay? Time. And this is the B scan, the two different, so the time period is March 7th versus April 18th. Not a lot of time. Not a lot of time,
Mhm.
but it's diagnostic, okay? This is blood in multiple layers. When you see blood in multiple layers in the retina, you've got some probably subretinal blood so thick it's dark, but could be RP. You got decolorized subretinal blood here, so they're probably of different ages. You got something here, dark blood here. Do you know what it is?
Is it a RAM?
What's a RAM?
Retinal artery macroaneurysm?
Right, you are. There it is. And that's typical what they do. They can bleed into multiple layers. They don't have to bleed into multiple layers, but they can. So if you see that, you think a macroaneurysm. And it evolved over time. And typically they regress. Typically, if you treat them, you occlude the artery. It is the hardest thing to just barely touch them with a laser and not go hard on them. So if they are feeding the macula, you might want to not treat, believe it or not. This is the first one I saw. This is from my fellowship in Iowa. This beautiful dome-shaped lesion. And again, an aneurysm. Notice the lack of fluorescence here in this blood. This must be between the RPE and the choroid capillaris. And with time, this is what happens. All right, there are other things. This is a dome-shaped lesion. I think I have a stereo pair, but maybe not. But you can see there's something here, right? How would you describe this? Is it heavily pigmented? What color would you give it?
Reddish.
And what's the diagnosis then?
Like hemangioma?
Yeah. So hemangiomas are typically described to my generation as filling very quickly on fluorescein, and that is diagnostic. And I submit that is bullshit, because melanomas are going to fill fast too, so is AMD, but this one just happens to fill very fast. I mean, we're not even into the arterial phase, and it is filling. It is rare to capture this.
Mhm.
Okay, I haven't seen. I've seen a bunch of these, and this is the only one I would show. Okay, so yeah, it fills now. It's really filling very fast. That's what it says. So I think that's wonderful, but this is the diagnostic criteria. They have incredibly high internal reflectivity. There's nothing else. I don't know of anything else that's going to give this kind of dome-shaped lesion with this kind of high internal reflectivity on B scan. And it's not, you don't have to be skillful with a B scan. This is just boom. Oh, wow. It's a hemangioma. So this is from Sandra Fraser Burns' book, which I loaned out to a photographer once that I never got back.
Cafeteria, so purple cafeteria.
Okay, so this is a melanoma, and the reason it has low internal reflectivity is it has a uniform cellular structure. There are no surfaces in there to reflect. So once the sound enters the thing, it's all uniform, so nothing gets reflected back. This one is the hemangioma. It has high internal reflectivity here, because there are multiple surfaces in between the vascular channels. So there are big vascular channels here and big pieces of fibrous tissue between them, and they are reflecting, and so you get this high internal reflectivity. And this is a metastatic lesion, which is variable, which has, some big chunks of fibrous tissue in it, giving you this type of peak. We do B scans now, and we've gone over that. So, but this is the anatomic correlation. All right, some other lesions that are pigmented that you might want to consider. Melanocytomas, non-Caucasians, usually adjacent to the disc. They're small, black, asymptomatic, they're slow growing, and they're the only lesion I've seen that will envelop a retinal vessel without, that envelops a retinal vessel. So notice how this covers the retinal vessels, this melanocytoma. Melanomas don't do that. They'll mushroom, but they rarely break through the retina. But they don't cover the vessels this way. It has fuzzy edges. It's incredibly dark. It doesn't fluoresce. And it has incredibly high reflectivity. Then there's the RPE and retinal hamartomas. Do they still call it that?
I think so.
Yeah, they call it combined hamartoma.
Yeah.
Combined
yeah.
hamartoma. Okay, see, I'm old, so these are charcoal. They're often near the disc, and they have incredibly number of microaneurysms, really tiny microaneurysms. They're associated with pre-retinal fibrosis, and there are reports in the literature of people peeling the fibrosis and getting some vision back. Here's one, and striae, and typically there's striae.
And these are young patients, too, right? They typically often.
I can't comment. Don't know. You're probably right. But I've seen them in old patients. The problem is they're noticed in young patients. They may be a congenital type lesion.
Yeah, it's more striking. Well, because in old people, we just call them macular buckets.
So well, no, they have this pigment, this charcoal pigment in them. And see, look at the tiny little aneurysms all the way through that. And they have a cellophane membrane. And it leaks. This is bear tracks. That's a three-toe bear.
That's bear track I've ever seen.
Huh?
That's the
Good one.
bear track I've ever seen.
Yeah, these photos go way back. This is when I was at the Johnson Clinic.
Also a diabetic, obviously.
Yeah, well, it's Johnson
That's like
Clinic, I
Johnson
mean.
Clinic, yeah,
You can't get in the door unless
Right.
you're diabetic, right? So
lots of stuff.
Johnson Clinic's interesting. So it was the eye service was founded by Bethel. Lord Aiello married his daughter. And then he became head of it. And he ran the diabetic retinopathy study. He was big in that. And I remember as a medical student going to fluorescein conferences. And he was just so enthusiastic. He was incredible. And now his son is head of it and is a full professor at Harvard and was at a very young age. And he's been a big investigator too. A really nice family, but I mean, it's a family business.
Mhm.
It just goes, I wonder if the current junior here has a junior coming along. I don't know. This is so RPE hypertrophy. So Veritrax is really a form of RPE hypertrophy. So you're going to see these things. These things they can have elevation, but it's not going to be more than 1 millimeter. And when they're elevated, it's flat. It's a plateau. It's like you call it a mesa in the Southwest, the flat top mountains, right?
Mhm.
A mesa or
Mesa.
mesa. So they're low mesas, okay? And they have very sharp borders. They're incredibly darkly pigmented. And they're not dome shaped. Okay, so let's keep going. And they have these lacunae. And lacunae could be most of the lesion. And this has a lot of lacunae. This is the biggest one I've ever seen, and it's all lacunae.
Mhm.
Here's one that's a little bit scary. But I think, I mean, it's fairly sharp border. It was a Mesa. You said it right.
Mesa.
Mesa. And it was dark. Had a little aneurysm there over it. I don't know why. But it almost looks like orange pigment there, but I watched it, didn't grow. This is another lesion, and this lesion, I remember Herschel Patel was on my service, and he diagnosed this. Excuse me, my nose is getting away from me. Do we have a?
It should be that.
Yeah, here's a nice map. Okay.
Thank God.
He diagnosed this by reading the record of the patient. I did not. So this is a dome-shaped lesion. It could be an amelanotic melanoma, it could be a metastasis, right? Herschel is great. And it has a fluorescence. And I didn't know what it was. It leaks. And you can see it leaks quite a bit. I mean, there's a neurosensory detachment over here. Okay. And it's got fairly high internal reflectivity, but it's got something else. Do the attendings know what it is?
Posterior scleritis.
Yeah,
It's gonna-
it's got this,
Thick
they
neck,
call it the
yeah.
T sign, right? But so we got half of a T here, right?
Yeah.
But this must be fluid, I think, behind the sclera from the inflammation.
Was there pain or anything like that? He was not. in
Yeah,
pain?
yeah,
He
there
must have
was.
been. Okay,
Yeah, yeah.
Well,
I mean, and Herschel, she'd had it before.
ah,
Oh.
So,
that's helpful, yeah.
and she'd responded before, but somebody took her off her medicine. You treat this with non-steroidal anti-inflammatories. I forget which one.
Like oral,
Yeah, oral at low dose. It's,
I think people like naproxen
Yeah.
twice a day or Dolabid or the CF. I think
I'm not, there's one more
sort of-
common than that.
Indomethacin.
Indomethacin is the one I used, yeah. And, you know, they don't respond to high dose steroids, you know, it's inflammation, but it's a different type of inflammation than you typically, hit them with steroids, right?
Mhm.
You might get, I don't know if you get any response, but you know, you don't have to, you just keep them on indomethacin for the rest of their life. And she kept coming back till I retired. And it resolves, it's flat now, all little pigmentary change.
Herschel was really good. He published with me while he was a resident.
He published a lot.
Yeah.
Yeah,
Do you know what happened to him now? What's he doing? He told me. He was,
with Mish.
and then they were screwing him in the PE deal and he was sad about that. I don't know what happened after
The
that.
PE is the,
They were
Private equity.
selling the
Yeah, sells the
practice.
to a corporation.
Yeah,
Yeah.
and I don't know what happened. I don't know how that all shook out.
Hello, we are honored. We are honored. Happy New Year. Nice to see you. Great to see you. So you're just in time for the finale.
Professor, good to see you.
So this is a lecture on lumps and bumps in the eye. What I call the differential diagnosis of ocular melanoma. There's a patient I saw. It was referred to me with this sort of pale lesion up here,
How are you? Good to see you.
and there was fluid in the macula. So this thing was leaking. And I did a fluorescein and I thought, oh, that's pretty rapid fill. It's not. I mean, this isn't show rapid fill. This shows that this is in the almost recirculation phase now. So, and but it fluoresced. And it was dome shaped. And by A scan, the reflectivity was, you know, it was so small, it was hard to get a good good things, but I said, oh, that's high. This has got to be a hemangioma. That's what I said. So I lasered it with a thermal laser in those days.
You always show this kid.
And
I don't know why you show these kids.
this is a great case.
It is.
I was a young whippersnapper, man. Okay, so and she got better. She resolved her edema and looked great. And she was lost to follow-up. I guess she was doing well. And then she came back. This is not the disc. This is covering the disc. This is a melanotic lesion with lots of vessels in it and a mushroom shape. And I thought I killed her. So we took it out. Oh, no, by the way, it's got good. This is a very typical decrescendo low internal reflectivity pattern for melanoma. So I was wrong. It wasn't a hemangioma. It was just a small melanoma.
You took the eye out, you're saying, right?
Oh, we took
Yeah,
the eye out. Yeah, at this
yeah.
point. Yeah. And Dr. Margot did a very nice job with the pathology. And these are all melanoma cells. I don't know what type. I think it was a mixed cell type, so
Yeah.
I thought she's dead. She's dead. She came back 10 years later, happy as a clam. Better be lucky than smart. This one, I got lucky. This is also an ultrasound. Does anyone know what this is?
The liver.
No, it's not liver.
Your grandson.
Yeah, it looks like it's a
Well,
obstetrical.
A, B is
Yeah.
Molly, and there they are.
Oh,
They're now 9 years old, and they are troubled. Oh, they're so much trouble.
where do they live? In these?
They live in Delaware. That's why I have a
Delaware,
house in
yeah,
Delaware,
yeah,
so I can harass them. So later, I got UBM much later in my career. And I started to get a lot of referrals for anterior segment pigment. And the most common referral is cysts. The UBM, you know how I talked to you about low internal reflectivity on B scan? If it's a melanoma, that's not true up front. UBM, if it's pigmented and it has high reflectivity, it's a solid lesion, you're probably going to treat it like a melanoma. And you can do an incredible amount of radiation to the front of the eye with impunity. What I got away with, I put on a 20-millimeter plaque covering the whole front of the eye, and it going down to more than 5 millimeters sometimes. And I take it off, the epithelium would heal, and 2 months later, you wouldn't know I'd done anything. It's really, I'm just appalled that I could get away
How do you
with it.
plaque the front of the eye? You just sew it up
You-
with limbus?
No, I mean, this thing is bigger than the limbal to limbal. It was
So you
12 mm.
you overlap the.
So you cover the cornea. Usually it's so typically if I were doing a plaque on this thing, if it were solid, which it probably was, I would be overlapping like this.
Uh-huh.
I mean, going way out. And on this, I would probably have the flanges up here, but on a big one, I wherever I could get the flanges to the sclera.
And they just hang out, they're really uncomfortable for a week and you take it off. And that's it.
They're not that
Okay,
comfortable.
not that-
Amazing.
okay.
They tolerate it.
Huh.
Let's see what else they got. Come on, go forward. That's not the last slide. I've lost control. Yeah, okay, so this is solid. So we put a plaque on it. It's not it's pigmented, it's solid, it gets a plaque. Keep going. This one. Keep going. It's a cyst. It gets watched. Commonly, if you have cysts, keep going. You'll see this. and you'll see just a little bit of sheen right here. Off of that, you'll see that as sheen. So that's the pigment, and then you have the non-pigmented epithelium. And there's a basement membrane in there, and you get a sheen off it, and you know then that it's a cyst. Okay, you get a UBM anyway, that's what you do, keep going. And that's another one, and they're cysts, but they're not isolated. If you have cysts like that in one eye, you'll have cysts other places in the ciliary body. If you look around the eye, and you'll also have them in the other eye, invariably. I would say 98% of the time. And this is a wonderful, I used to, this was easy money. Everybody's happy, you're fine, go away, you're gonna be